get a hemoglobin electrophoresis done, especially if it's a belt where thalassemia is very prevalent. So we get the woman's HB electrophoresis done, and if she's thalassemia minor, then we get the father's thalassemia screening done, because if both are thalassemia carriers, then there's a 25% chance the baby has thalassemia major. So this is two additional investigations which are not routinely recommended for everybody, but in certain high risk areas we do these. So these are the routine blood tests that are recommended in pregnancy that need to be done. Now coming to screening for pregnancy associated conditions, in this we have screening for preeclampsia and we have screening for diabetes. In screening for preeclampsia, we've discussed this. We check the history, we calculate the mean arterial pressure, we do an ultrasound, and all this is done between 11 to 14 weeks. Okay, and we see the pulsatility index of the uterine artery, it should be less than 1. More than 1 is a risk factor for preeclampsia. Okay, and we check the biochemical factors. Here we check the one starting with P, placental growth factor, placenta associated plasma protein A, and the growth factors V, E, G, F. In a woman who is going to develop preeclampsia, these values are going to be found to be low. And two others, soluble endoglin and SFLT1. These are going to be high. The ones starting with S are going to be high in a woman who develops preeclampsia. So history, mean arterial pressure, uterine artery, PI, and these biochemical markers, all these are put into a software. Okay, and the software will tell us whether she's high risk or low risk for preeclampsia. This is how a uterine artery Doppler looks like. This is a normal uterine artery and this is an abnormal uterine artery. Can you see the notch here? This notching is another thing which we look for, but if you're looking for the notching, sometimes it will be too late because persistence of the notch is important. The notch can be seen in the second trimester, but if the notch is persisting after 24 weeks, it again increases the risk of developing preeclampsia. But we don't want to wait till 24 weeks, right? That's why we do the other things, that is the medical history and the mean arterial pressure, the uterine artery PI, the biochemical markers. We put everything together in the software. It will give us a preeclampsia risk calculation. If she's low risk, offer her routine care. If she is high risk, what will we do? Start low dose aspirin. And this is very important. It should be started before 16 weeks of pregnancy for it to inhibit early onset preeclampsia. So it reduces the incidence of early onset preeclampsia, that is preeclampsia developing before 34 weeks of pregnancy. Screening for diabetes in pregnancy, we've already discussed screening of overt diabetes, right? In the first trimester, we will do an HbA1c or a FBS or a RBS. And if all is normal, then we call the patient for the next screening at 24 to 28 weeks, where we do either the 75 gram OGTT, where we ask her for a fasting sample, give her 75 gram glucose and check the values at 1 hour and 2 hour. The cutoffs for this are 92, 180 and 153. Any one value abnormal and she becomes GDM. Okay, gestational diabetes, not overt. Overt is pre-gestational. Here we are screening now for GDM, gestational diabetes. But many times the patient doesn't come fasting, and these are the international guidelines. They're not specific for our country, where patients will be lost to follow-up. If she doesn't come fasting now, she may never turn up, right? So in our country, we very commonly follow the DIPSI test. This is again done preferably at 24 to 28 weeks, where we again, what do we do? Irrespective of the prandial state, she may be fasting, she may have just had a samosa, it doesn't matter. We give her 75 gram glucose and after 2 hours we check the value. Anything more than 140 is diagnostic of GDM. So this is a screening plus a diagnostic test. Both these tests, this one and this one, the international guidelines and the DIPSI, both are screening plus diagnostic. So you don't have to do any other additional tests. They both screen and they both diagnose GDM in pregnancy. So this is the DIPSI, the values. If it's more than 140, she is GDM. Okay, if it's more than 200, it is very likely she's actually overt diabetes. And if she's more than 120, it's called as decreased glucose tolerance, decreased gestational glucose tolerance, and you have to be a bit careful and you may repeat the DIPSI test after a few weeks. Now coming to screening for Down syndrome. Down syndrome we all know is trisomy 21, and the most important risk factor, if we don't have any test available to us, is the age. Every woman has a background risk, and this background risk is based on her age. The more her age, the elder she is, the higher the risk of Down syndrome. Okay, at 25, remember these two. At 25, the risk of having a Down syndrome baby is 1 in 5,000, and at 45 it's 1 in 20. It's very, very, very high. So that's most important. But we can't use just age as a screening test. We have to build on and add value to it. So when can we screen for Down syndrome screening? Apart from age, the patient at 11 to 14 weeks, we can do an ultrasound where what do we look for? We look at the nuchal translucency. That is the neck, the skin at the back of the neck more than 3 millimeters is very high. Not necessarily Down syndrome, but it can be increased in other aneuploidies, other structural problems also. Along with the NT, on the scan, we look for the presence or absence of a nasal bone. An absent nasal bone is common in Down syndrome. Okay. Also, tricuspid regurgitation and abnormal flow in the ductus venosus, the vessel. Okay. These three are additional things we look for on the ultrasound at 11 to 14 weeks, which are markers for Down syndrome. But primarily, we're talking about the NT. We also can do at that time a biochemical serum analysis where we look for two things. We look for the PAP-A again, and we look for the beta HCG. Anything with B is going to be increased in a baby whose mother has Down syndrome. It's going to be increased in the mother whose baby has Down syndrome. So beta HCG values are going to be high, PAP-A are going to be low if that baby she's carrying has Down syndrome. Okay, so ultrasound, that is the NT scan plus the biochemical serum analytes. And what we do usually is we do both together. Not only ultrasound, not only biochemical, we do both together. So if somebody asks you or tells you a combined screening for Down syndrome was done. Combined means simply you're doing both the nuchal translucency plus the double or the dual marker. Both are being done. So this of course will increase the detection rate. Okay, and of course we have the age also with this. So with this we have a good detection rate, and remember this is a screening test. So if this is positive, if this is showing a high risk for Down syndrome, we are going to ask this woman to undergo a diagnostic test, which could be either a chorionic villus sampling or an amniocentesis or a chordocentesis. This is how the NT looks like. This can come as an image-based question. This is the NT we are measuring, the thickness of the back of the neck. Beta HCG is going to be increased, PAP-A is going to be decreased in a mother whose baby has Down syndrome. Second trimester screening, remember if the woman has missed her first trimester screening, she comes late, we can also do a second trimester screening where here primarily biochemical markers become more important. We have two things. We have a triple test which is no longer done, and we have a quadruple test which is more commonly done now. In the triple test, and we also have the ultrasound. Ultrasound, remember, this is the targeted imaging for fetal anomaly, but remember aneuploidies may not have proper actual structural anomalies. They may not be an obvious cardiovascular disorder or a neural tube defect or a cleft, but there may be subtle things, suggestions like a sandal gap, like brachycephaly, like clinedactyly, which may be seen. So you may miss it on the ultrasound, and that's why the biochemical screening is more important. In biochemical screening, these three form the triple test, and if you add to it inhibin A, it becomes the quadruple test. Remember, B jahan pe hai, wherever B is, it's going to be big, right? So it's going to be increased, and alpha fetoprotein and unconjugated estriol are going to be decreased. Remember, it's A, it's not B, and this has come as a question twice now. It's inhibin A, it's not inhibin B. But we're looking at this B, inhibin, beta HCG, both are increased in a mother whose baby has Down syndrome. So these are the subtle features. They're also called as soft tissue markers, which you may be able to see on the ultrasound. If the baby has Down syndrome, you have brachycephaly, you have mild ventricular dilatation, you can have clinedactyly, you have a small or undeveloped nose, sandal gap, widened pelvis, kidney, minimal renal pelvic ileal dilatation. Okay, then nuchal thickening again at the back of the neck, but this is called as nuchal thickening. It's not called as nuchal translucency. That term is used only for 11 to 14 weeks pregnancy. Okay. Now, very important and a question which is now increasingly being asked is there any other screening test which has a much higher detection rate? So remember, there's something called as non-invasive prenatal screening or cell-free DNA. This has a detection rate of 99%. That is the highest detection rate. So you don't need to do all the double, quadruple, NT, all that. Simply offer the mother a NIPT. But the problem with this, it's very expensive. That's why we can't just offer it routinely to everybody. It is very expensive, but it's very, very good. Okay. What do we do here? Here we take a maternal blood sample, and in the blood sample, what is looked for? Apoptotic trophoblastic cells are looked for. Apoptotic trophoblastic DNA is looked for. So what happens is, from the placenta, you have these apoptotic trophoblastic cells which enter the maternal circulation and they break down and release trophoblastic or placental DNA. And this DNA is then analyzed and looked for any problems in this DNA. Okay, but remember, it is a screening test. It is not a diagnostic test because we're not sure where this placental DNA has come from. Maybe it was from a vanishing twin. There may be placental mosaicism, so we're not very sure. So it remains a screening test, but with a very, very high detection rate, almost 99%. It can be done any time after 9 to 10 weeks. Okay, so remember, 10 weeks ke baad it can be done. It is only a maternal blood sample. It has a very high detection rate. You're looking for placental DNA, but it remains a screening test. If it comes positive, you still have to do a diagnostic test. What are the diagnostic tests? We have 3 diagnostic tests. Chorionic villus sampling, which can be done at the earliest between 10 to 13 weeks. Then we have amniocentesis, where you can do between 15 to 20 weeks. And then you have chordocentesis, that is, you're directly taking blood from the umbilical vein. This can be done after 18 weeks of pregnancy. The most commonly performed one, however, is an amniocentesis, because all these, the double marker would be done between 11 to 14 weeks. By the time the report comes, this woman is usually counseled for an amniocentesis between 15 to 20 weeks. Know how these look like? This is an image-based question, a picture. A question can come. It has come in the past also. See, this is the ultrasound probe. This is the needle going in the amniotic fluid, and amniotic fluid is aspirated out. This is a chorionic villus sampling, which can be done even earlier. It can be done transvaginally, like you can see here. It can also be done transabdominally. What is done is a needle is put again under ultrasound guidance, and chorionic tissue from the placenta is aspirated out and sent for chromosomal analysis. This is a chordocentesis. This can be done only much later on, 18-20 weeks ke baad only you can do this, where a needle is put in the umbilical vein and blood is aspirated. And this is much quicker though, because fetal blood you can culture very, very quickly and you get a report very, very quickly. Okay, now moving on to the last topic of antenatal care, and this table you should know. This is the teratogens. All which I have mentioned here, all have come in previous year questions. Okay, so teratogenic drugs are again a very favorite of the exam. Anti-epileptic drugs, remember fetal Hayden-Toyne syndrome, especially with phenytoin and phenobarbital. What do they cause? They cause facial features and distal digital hypoplasia, small fingers. Okay. Then AC inhibitors, ARBs, we've discussed this. Fetal renal hypoperfusion leading to early onset oligohydramnios, leading to Potter's sequence. Okay. Alcohol, fetal alcohol syndrome. Lithium causes Epstein's anomaly, and in the neonate, it can cause neonatal lithium toxicity. And that is why this has come as a question. When the woman is about to deliver at term, you can decrease the dose of lithium if she's on lithium, or stop the lithium for some time, because this will prevent neonatal lithium toxicity. Indomethacin, we've discussed. After 32 weeks, you're not going to give it because it causes premature closure of the ductus arteriosus. Methimazole for hyperthyroidism causes cutis aplasia. Warfarin causes warfarin embryopathy in doses of more than 5 mg per day. Should not be given in the first trimester and also in the third trimester, because in the third trimester it increases the risk of neonatal intracranial hemorrhage. Thalidomide was a drug which is no longer given. Okay, it is known to cause phocomelia or shortened limbs. Methotrexate causes craniosynostosis or clover leaf skull. DES, diethylstilbestrol. What does this cause? This causes clear cell adenocarcinoma of the vagina or the cervix. It also causes Mullerian anomalies, a T-shaped uterus, and in the male baby, it can cause hypospadias or microphallus. SSRIs, recently asked, SSRIs are usually safe, but paroxetine can cause cardiac defects, especially VSD. And other SSRIs, when the baby is born, it causes something called as neonatal behavioral syndrome, which is a short 24 to 48 hours. It's like a withdrawal of the neonate from the drug. So the baby will be jittery, crying episodes, irritability, which will gradually settle down. It can also cause primary pulmonary hypertension. So these are teratogens. This table is very, very important. You should know this. Teratogenic exposure is usually asked in one of the papers. And to finish the topic again, we will discuss imaging in obstetrics. We've already discussed early pregnancy. Here you can see an intrauterine gestational sac. Okay, and this will appear at 5 weeks on a TVS and 6 weeks on a transabdominal scan. You can also see here the double decidual sac sign. This is formed in an intrauterine pregnancy and is formed by, remember, capsularis and parietalis. Decidua capsularis plus decidua parietalis are going to form this double decidual sac sign. This is the yolk sac, okay, and this is the gestational sac. The yolk sac appears at 5.5 weeks. It is the first anatomical structure to be seen within the gestational sac. This is the fetal pole, okay, and if you see a real-time scan, you'll see the cardiac activity also beating. Sometimes this you see a faint amniotic sac in which the fetus is in, and this amniotic sac plus this yolk sac are going to form what is called the double bleb sign. So it's formed by the amniotic sac, very thin structure, and the yolk sac. Okay, this is the double bleb sign. So this is the fetal pole, this is the yolk sac, and this is the amniotic sac. So here you have the double bleb sign. What is this? We've discussed this. You can see inside the uterus some fluid collecting. This is a pseudo sac seen in ectopic pregnancy. It is not a real intrauterine sac. It is just collection of fluid. So this is the nuchal translucency, which you can see measured here. These are, again, we've discussed all these. So quick revision. This is the snowstorm appearance of a complete mole. This is the bagel sign of an ectopic, tubal ectopic unruptured pregnancy. This is Buddha sign. Buddha sign is when there is hydrops, the baby, there is scalp edema. So in scalp edema, you can see here is the skull, and around the skull, you can see this shadow here. So it's nothing but the subcutaneous tissue, which is edematous, and this is called the Buddha sign if it's seen over the fetal head. This is Spalding sign. Spalding sign is seen in intrauterine fetal demise, usually happening after 1 week of fetal demise. You see the Spalding sign. And remember, in Spalding sign was initially described as an X-ray finding, but you also see it in ultrasound. This is the banana and the lemon sign. Again, very, very commonly asked question. Banana sign is when the cerebellar curvature is increased, and lemon sign is pinching of the calvarium. Both are seen in spina bifida. This is double bubble sign seen in duodenal atresia. This is keyhole sign seen in posterior urethral valve. There is an obstruction, bladder outlet obstruction, and this is also going to present as what? As oligohydramnios. The amniotic fluid is going to be very, very less because the baby is unable to pass urine. This is anencephaly. You can see the frog face appearance here. And if you look at the sagittal view, both have come as questions. Both views have come. You can see there is an absent skull here. So this is anencephaly. This is the lambda sign seen in dichorionic diamniotic twin. And this is the reverse T or inverted T sign seen in monochorionic diamniotic twins. So we stop here, and then the next topic we will continue is with labor and all important labor related topics. Now moving on to a rapid revision of labor. This will include both normal and abnormal labor and all the important things you need to know. Now remember, in labor we talk about two things when we talk about the mechanism, we talk about the pelvis and the fetus. Now, in the pelvis, remember, it's not a cylinder. It is a structure where the bony pelvis is different at the inlet, at the mid cavity, and the outlet. So that means the pelvis has three parts. It has an inlet here. It has a mid cavity in the middle. So the inlet is here from the pubic symphysis till the sacral promontory. Then you have an outlet, which is again from the pubic symphysis till the sacrococcygeal joint or till the tip of the coccyx. And then you have this whole part in between is the mid cavity. And in the mid cavity, you have two planes. One is the plane of greatest dimension, and then you have a plane of least dimension. The greatest dimension is the widest part of the pelvis. It's like a circle. But the least dimension is the narrowest part of the pelvis. So this is where most problems in labor are going to happen. This plane lies at the level of the ischial spine. So if you have the pelvis here, this is where the ischial spines are. This is where this plane lies. Okay, it's also called as zero station. When we check when we do a PV and we check where the fetal head is, this is where zero station is. Okay, so it's the narrowest part of the pelvis. It is where the levator ani is originating from. It is where the curve of the pelvis changes. Can you see how the pelvis is changing from downwards and backward to downwards and forward? And this change is happening at this plane. This is also sometimes in forceps and vacuum deliveries, we give a pudendal nerve block. This is the level at which we give it. This is where deep transverse arrests happen. We'll be talking about this more in occipito-posterior position. This is the plane of internal rotation. When we talk about mechanism of labor, one step is internal rotation. It's happening at this plane. And this is also where the head, if you can palpate the head at the level of the ischial spine, this is called as zero station. Anything above is minus, anything below is plus. Okay. Now, another important aspect are the types of pelvises. So, there are four types of pelvises. The first you can see here is a gynecoid pelvis. A gynecoid pelvis is a normal female pelvis. It is the widest pelvis. Okay. And here normal labor is going to happen. You don't expect any complications because of this pelvis. Also remember, a gynecoid pelvis has a more wider transverse diameter at the inlet. So, the transverse diameter at the inlet is more than the anterior-posterior diameter at the inlet. The second kind is the android pelvis. Look at this pelvis. Can you see at the inlet what is the shape? It is a heart-shaped pelvis. And remember, android is a male kind of pelvis. Okay. Here you have maximum problems. You have a small inlet because of the protuberant sacral promontory. You have prominent ischial spine, so you have a small cavity, and even the outlet is small. So it's a small pelvis through and through. You get a lot of obstructed labors here. A lot of deep transverse arrests happen in the android pelvis. So it's not a good pelvis to have. Then we have the anthropoid. Anthropoid is also called an ape-like pelvis. And you can see here at the inlet, you can see the AP diameter is much more than the transverse diameter. And anthropoid is specifically famous for occipito-posterior positions. You see occipito-posterior and android also, but if the question comes, it is more likely to be an anthropoid than an android pelvis. And the last is the platypeloid. Platypeloid is the transverse diameter is very, very long. It's a flat pelvis throughout. And here what commonly happens is something called as asynclitism. That means asymmetrical engagement of the fetal head. Okay, and also some places do mention that face presentation is also more common. So remember asynclitism and face presentation in a platypeloid pelvis. Okay, next we come to the skull. In the skull, we talk about certain things. We talk about the bones in the skull. So you have two parietal bones, you have two frontal bones, and you have an occipital bone at the back. Then you have the suture lines between these bones. So the central suture between the two parietal bones is called the sagittal suture. This is the sagittal suture. Here you have a frontal suture between the two frontal bones. Here you have the coronal suture between the frontal and the parietal bones. And here you have the lambdoid suture between the occipital and the parietal bones. Now, the meeting point of these suture lines is called the fontanelle. So, we have two main fontanelle. We have an anterior fontanelle here, which is the meeting point of four suture lines. Okay, and you have a triangular posterior fontanelle here, which is the meeting point of three suture lines. So, you should know that the posterior fontanelle is triangle, three suture lines. Anterior fontanelle is diamond shaped and meeting point of four suture lines. Also remember, in a deflexed head, which fontanelle will you feel? You will feel the anterior fontanelle. And in a well flexed head, which fontanelle will you feel? You are going to feel the posterior most point, because the baby's head is flexed, so you will feel the posterior part of the head. That is the posterior fontanelle, and that's why these two fontanelle are important, because we're not seeing, we're doing PV examinations here. Now also remember transverse diameters of the skull and anterior-posterior. So when we talk about skull diameters, there are two types. One is the transverse diameter, and the maximum transverse diameter is the biparietal diameter, which is 9.5 centimeters. This is the diameter of engagement. Okay, and this is when engagement happens in syncretism. That means in symmetrical engagement, it is biparietal diameter. But if the engagement is happening in asyncretism, that means it is asymmetrical, then the super subparietal diameter is the engaging diameter, this one here. Okay, and this is 8.75 centimeters. Some books say 8.5, you can remember 8.5 or 8.75. So BPD is the one to remember. It is the largest transverse diameter of the pelvis. It is the diameter which is the engaging diameter in syncretism, and this is 9.5 centimeter. If the head engages in asyncretism, then the diameter is smaller, super subparietal diameter, which is 8.75 centimeter. Then we have the antero-posterior diameters, and these depend on the degree of flexion or the attitude of the baby, flexion or extension. How is the attitude? The AP diameters will change. Remember, in all these different flexion attitudes, the transverse diameter is not changing. It remains the biparietal diameter. What is changing is the AP diameters, which we will just discuss in a bit. Okay. There is a phenomena called molding. Molding is when during labor the head gets compressed, because the pelvis is a confined space, and the suture, the spaces between the suture lines come closer together. The space is around 4 millimeter between two suture lines, and as labor progresses, the suture lines come together. So this area gets obliterated. Here, this is grade 0 molding. That means no molding is happening here. This is grade 1 molding, where the suture lines have approximated. This is grade 2 molding, where they have overlapped, but if with your finger you can push away the suture bones. And this is grade 3 molding, where it is so tightly overlapped that you can't even push it apart. And this is a feature of obstructed labor. Remember, grade 3 molding and grade 3 caput. So significant caput. What is caput? It is the swelling on the fetal scalp because of stagnation of fluid in the layers of the scalp, because it's been in contact with the cervix or the pelvic floor for a very long time. Remember, it is not limited by the skull bones. It is a diffuse scalp swelling, and hence it's important to differentiate it from a Keffel hematoma. A caput succedaneum is present at birth. You'll see this at birth, and it does not increase in size. In fact, it will lessen in a few hours, 2 days, it will completely disappear. Whereas a Keffel hematoma is going to appear after birth, and it increases in size gradually for 2 to 3 days. Okay, now a caput is not significant. Keffel hematoma can lead to complications. There could be an underlying skull fracture, because it's blood. It's not a simple diffuse accumulation of fluid. It is blood. So there could be connectorous, raised bilirubin levels leading to connectorous. There could be an underlying skull fracture. And very importantly, how do you differentiate it on examination? It is limited by skull bones. Okay, here it is not limited by skull bones. It is a very diffuse sort of swelling. Okay, now basic definitions. Why I've put this together is to make you understand the different diameters. So what is lie? Lie is this: whether the baby is longitudinal, oblique or transverse. That means that the relationship of the long axis of the fetus to the long axis of the mother. So here you have longitudinal lies, here you have oblique lie, and here you have transverse lie. Then you have presentation. What is presentation? The part of the fetus that is occupying the lower pole of the uterus. you have here cephalic presentation, here you have breech or podalic, and here in transverse lie you have shoulder presentation. Then you have different attitudes, presenting parts, and accordingly denominators, and here we will discuss the diameters based on the different attitudes. Here there is an attitude of complete full flexion. This is a deflexed head. This is a partially extended head, and this is full extension. So these are the different attitudes. Okay, so full flexion, deflection, partial extension, and full extension. Now, based on these different attitudes, we have number one, different presenting parts. So in all of them, the presentation is cephalic. In here, the presenting part is the vertex. Here also the presenting part is the vertex. Here the presenting part is the brow, and here the presenting part is the face. Okay. Now, what is denominator? Denominator is an arbitrarily chosen point, usually a bony prominence, which we use to describe position. So here we will take the occiput as the denominator. Here also, just for sake of convenience, we take the occiput itself as the diameter, as the denominator. Here we take the frontum, this part, the forehead, most prominent part of the forehead is the frontum. And here we take the chin, that is the mentum, as the denominator. Okay, so these are the different attitudes in cephalic presentation. You have full flexion, deflection, partial extension, full extension. Okay, and based on that, we have different diameters. So in a well-flexed head, okay, and this you can see the attitude is moving from flexion to complete extension. So for complete flexion, you have a well-flexed head. This is the presenting diameter. In fact, it's more of a diameter like this. This is the suboccipitobregmatic diameter, or SOB, which is 9.5 centimeters. So we have the biparietal diameter, which is the transverse diameter in all these attitudes, that is also 9.5 centimeter. In the AP diameters, we have fully flexed head, suboccipitobregmatic, 9.5. Then we have a deflexed head. It's neither flexed nor extended. It's standing straight. Okay, so this is a occipitofrontal diameter, which is 11.5 centimeters. Then we have partial extension, where the presenting diameter is now from the mentum till the vertex. This is the diameter. Okay, this is a verticomental or a mentovertical diameter, which is 13 centimeters. Just correct this. This is a verticomental diameter, which is 13 centimeters. And some books would say 14 centimeters also. Okay, remember 14 centimeters, remember verticomental. And look at this. This is face presentation, where this is the diameter. What is this diameter? This is the submentobregmatic diameter. This is also 9.5 centimeters. So we have three diameters which are 9.5. The biparietal, the suboccipitobregmatic, and the submentobregmatic. These are all 9.5 centimeters. The largest presenting diameter is in brow, and because the diameter is so large, brow does not have a mechanism of labor. That means brow, if it remains brow, cannot deliver vaginally. And lastly, we have something called position. Position is how the fetus is in relation to the different quadrants of the maternal pelvis, right? And so we take the denominator, like here there's a fully flexed head. You can see the denominator is the occiput. The occiput is pointing towards the left side. Now, how do we know which is left, which is right? Look at how this pelvis is. Can you see this pelvis? This is of a woman who is standing right in front of you. So first thing you need to determine when the image is shown is which is posterior, which is anterior, which is left, which is right. That's the first thing you need to know. And then just see where the denominator is in which quadrant of the pelvis. For example, this is left occipito-anterior. This is left occipito-anterior. This is left occipito-transverse. This is left occipito-posterior. This is right occipito-posterior. This is right occipito-transverse. This is right occipito-anterior. So these are the different positions you can have. And of course, you can have direct occipito-anterior and direct occipito-posterior. So all in all, how many different positions can there be? There are 8 possible positions you can have with respect to different quadrants of the maternal pelvis. Questions that come from here is an image will be asked. Like we'll show you this image and they'll ask you what is this. So first, as I said before, look what is posterior. This is posterior. This is anterior. Okay. This is posterior. This is anterior. Then see where the occiput is, or which is left, which is right. So this is a woman standing in front of you. So this is going to be the left side and this is going to be the right side. Yeah, this is the right side. Okay, next you look where the occiput is. So you can see the occiput is here, right? And it is anterior and it is towards the right side. So it's right like this. Okay, so this is right occipito anterior. And that's how you would determine the position by seeing an image like this. Okay, so just orient yourself, see which is anterior, posterior, which is left, right, and you will easily understand this. Now coming to mechanism of labor, we won't go into too much detail. All of you have your own mnemonics to remember, but remember this, remember the order. Every darn fool in Egypt royally eats raw eggs. The first step is engagement. That is when the largest diameter of the fetus, the largest transverse diameter of the pelvis enters the or crosses the pelvic inlet. This is the biparietal diameter in cephalic presentation. Okay, and this is engagement. The next is descent. Remember, descent is put as the second step, but it is actually a continuous process happening throughout. Okay, it's not like it's happened and then stopped. No, it will continuously happen till the baby comes out. Then you have flexion. That is, the flexion of the head is most important because the diameter becomes smaller and smaller. The baby becomes more compact. Then internal rotation happens at the level of the ischial spine. Okay, and this will be in a direction in such a way that it becomes occipito anterior. So if it is LOA, it will move by 45 degree to become occipito anterior. If it is LOT, it will move by 90 degree to become occipito anterior. So this is the amount of rotation that happens. Then you have extension. So the head is born by extension. Okay. And I'm talking about left occipito anterior, which is the most common position we have. So the head is born by extension. And then what happens? Restitution happens. That is untwisting of the twisted head. Okay. So the head will go back, move back by or twist back by, untwist by 45 degrees because now it's free of the pelvis. And then what's happening is the shoulders now enter the pelvis and are undergoing internal rotation. So if the shoulders move, the head is also going to move. How do we know the shoulders are going internal rotation? Is when we see external rotation of the head. So by 45 degree, the head is going to rotate. And then finally, the body will come out. First, the anterior shoulder is delivered. Then the posterior shoulder is delivered. So now we move on to induction of labor. What is induction of labor? Induction of labor means starting something. Induction means starting something. So you want to start labor in a woman who is not already in labor. Okay. So you want to induce labor pains so that she goes into labor. What are the indications? Why do you want to do this? There could be so many indications. We've discussed so many of them in medical disorders of pregnancy. But just to tell you a few, if the woman has gone past dates, if she has pre-labor rupture of membranes and has not gone into labor spontaneously, say she is pre-eclampsia, mild pre-eclampsia at 37 weeks, she's not gone into labor, you want to induce her. Say she is intrahepatic cholestasis of pregnancy, she's reached 38 weeks, you want to deliver her, she's not gone into labor. Say she is a patient with oligohydramnios at term, you want to induce her, or fetal growth restriction at 37 weeks or 34 weeks with severe FGR. So many indications. Whenever you want to, you've taken the decision to deliver the patient, you know you want to, you're aiming for a vaginal delivery. Remember, your aim is to achieve a vaginal delivery. There's no point inducing her if you're going to do a cesarean section. This is your aim. You may or may not reach the aim. But if your aim is vaginal delivery, then you have to induce the patient. If say she is placenta previa and she's 37 weeks, you won't induce her because you know you're going to do a cesarean section or there's cephalopelvic disproportion. There's no point getting labor pains in her. She's going to end up in a cesarean section. So IOL, induction of labor, is for those women who you want to achieve a vaginal delivery. Okay. And to decide the favorability of that patient for achieving a vaginal delivery or for responding to your induction is called a modified Bishop score. So this is a score which we do when we do a vaginal examination. Say a patient comes at 41 weeks. I've decided to induce labor pains because she's not gone into labor. Till now, I will do a PV and I will calculate her Bishop score. This score will tell me how favorable she's going to respond to induction and I can counsel the patient accordingly. So this Bishop score is very important. It's usually asked as a question. What are the components of the Bishop score? The components are 5 components. You have cervical dilatation, cervical length, which was earlier called as effacement, cervical consistency, position and station. Okay. And each is given a score. Very easy to remember this. Bishop itself is a mnemonic. B stands for Bishop. I stands for effacement, but with a I. Okay, S stands for station. H stands for hard or soft, that means consistency. O stands for os, dilatation, how dilated the cervix is. And P stands for position of the cervix. Okay, so you have 5 components. Each is given a score of 0, 1, 2, 3. Okay, except for position and consistency, which get a score of 0, 1 or 2. There's no 3 in this. Okay, all the others are given a score of 0, 1, 2, 3. If you're preparing for INI, you should know this table. It's a little difficult to remember, but it's important for INI. For NEET PG, remember the components. Okay, and remember that the highest score is 13, the lowest score is 0. And what is a favorable score? A favorable score is one which is 6 or more. What does this mean? So if the bishop score is 1 or 0 or 2 or low, a poor bishop score, that does not mean I won't induce her. That just means that the favorability is poor. So the chance that she may that she may not respond to the induction is higher. The chance that she may take more time to respond is also higher. That does not mean she will not deliver. So please understand that even if it's an unfavorable bishop, she can still have a vaginal delivery. It may take more time. Now the next question is, how do we induce labor? We've decided we're going to induce. Okay, the Y is done. Why we want to induce, the bishop scoring is done. Next is, how will we induce? So we have medical methods. In medical methods, we have prostaglandins, which we can use. In prostaglandins, we have PGE1 and PGE2. PGE1 is also called as misoprostol. Okay, it is a very strong uterotonic. So you want to give uterotonics or medicines which will contract the uterus to achieve labor. Right, and then we can use PGE2. PGE2 is dinoproston. We can use either of them to induce labor, or we can use oxytocin. So these are the medical methods, right? This is misoprostol. It's available as a tablet. If you're using it for induction of labor, it is used in very small doses of 25 microgram tablet. It can be given orally or vaginally or sublingually. Okay, and then the dose can be repeated every 4 to 6 hours. Okay, but it's a very strong uterotonic and it's not very commonly given for induction of labor because of the known side effects, that is strong uterine contractions can lead to fetal distress, meconium aspiration. It can even lead to rupture uterus sometimes. PGE2 is more commonly used. It is available as a tablet, which is available both as an oral and a vaginal tablet. It's available very commonly as an intracervical gel. And it's also available as a vaginal pessary. The third one is called, it looks like this. It's called as ProPess. It's a vaginal pessary. Okay, with a thread. So the thread is there to pull it out. So dinoproston acts more, it's not as strong as PGE1, so it doesn't cause sudden uterine contractions. It causes slow cervical ripening and eventually the patient will go into labor. Then we have oxytocin. Oxytocin has so many uses. More than induction, in fact, is very commonly used for augmentation of labor. Is a more common use. Okay, we will read about oxytocin in postpartum hemorrhage, prevention and management, but it's also used for induction of labor. It's used as an IV infusion. Okay. Next, we have surgical methods. In this, we have two. We have sweeping of membranes and we have artificial rupture of membranes. What is sweeping of membranes? Is when you do a PV and the cervix is slightly open, where you can introduce your finger, you sweep the membranes. Can you see this is before sweeping and after sweeping? What has happened? The membranes have separated from the underlying decidua in the part where your finger can reach. And what does this do? This causes release of prostaglandins, and prostaglandins are known to induce labor. Okay, but what are the side effects or the drawbacks of it? It can lead to pre-labor rupture of membranes, because if this area is weakened, the membranes can rupture, and it can also lead to introduction of infection. So choreo amnionitis can happen. Okay, so this is sweeping or stripping of membranes. Another technique is ARM. What is ARM? ARM is artificial rupture of membranes. Again, this is more commonly done for augmentation of labor than induction. One reason why it's not commonly done for induction, you have to have a very favorable Bishop score to do ARM, because the cervix should be at least 3 centimeters dilated for you to do a artificial rupture of membranes. Otherwise, it becomes very difficult to do this. But the biggest advantage is that you can see the color of amniotic fluid. So if there's meconium or blood, if there is you're anticipating fetal distress or abruption, you can see the color of the amniotic fluid when you do an ARM. Okay, you can do an ARM using either an amnio hook. This is an amnio hook, or you can do it using this instrument. This is a Coker's forceps. Now, there's another way you can induce labor is by mechanical methods, and you can do this by introducing. It's not available in India, but in the West, it's very commonly used. Laminaria tents. These are made of seaweed and they are hygroscopic. What does that mean? You insert this into the cervix and this swells up. It absorbs water from surrounding tissue and it swells up and opens the cervix. In India, instead of this, what do we use? We use a Foley's catheter. We don't have the laminaria tent, so we put in a Foley's and we inflate the bulb with saline. What does that do? That opens up the cervix mechanically. It also separates the membranes like in a sweeping, and prostaglandins are released and such patients go into labor. Now, amongst all these methods of induction, remember that where will you prefer what method? Remember, if the woman has a previous lower segment cesarean scar and you want to induce labor in her, what will you do? You can induce. Remember, previous LSCS is not a contraindication for vaginal delivery. Previous upper segment is. So, previous LSCS, if all other factors are favorable, you can induce labor in her, but avoid prostaglandins. They are absolutely contraindicated because they cause sudden uterine contractions. Oxytocin, used with caution. So, what method should you prefer in a woman with a previous LSCS who you want to induce labor in? Prefer mechanical methods. These ones, the laminaria tent, or what we have in our country, a Foley's catheter. So, if the question comes previous LSCS, you want to induce labor, think of a Foley's catheter or a laminaria tent. Don't give her prostaglandins. Now, coming to management of labor. Now, management of labor again is a very vast topic. To keep it brief and short, we are mainly discussing the recent WHO intrapartum care guidelines. Okay. Before that, what are the stages of labor, or how many stages are there? There are 4 stages of labor. Stage 1 is from the onset of true labor pain till full dilatation of the cervix. Stage 2 is from full dilatation of the cervix to delivery of baby. Stage 3 is from delivery of baby till delivery of placenta. Okay, and stage 4 is a 1-hour observation period following delivery of the placenta, because this is when maximum complications can happen, like postpartum hemorrhage, postpartum collapse, amniotic fluid embolism. So you're going to be very vigilant in this 1-hour post-placental delivery period. Now, in 2018, this document came out, and since then it's very commonly being asked in the exam. It's also changed a lot of things, a lot of ways we practice have been changed based on this. So it's important to know this. Along with this came the labor care guide, which has replaced the WHO modified partograph. So we will be discussing that also. Now, what does this guideline say? It says throughout labor, what should you do? You should respect the mother, that is RMC, which is also a very important component of Lakshya. What is Lakshya? Lakshya is Labor Room Quality Improvement Initiative, that is standardizing labor rooms throughout the country. And RMC is a very important component of both the WHO guidelines and Lakshya. Okay, effective communication, companionship, and continuity of care. These 4 are components of the guideline of throughout labor. Then the guideline further goes on and divides in the first stage what you should do, what you shouldn't do, second stage, and similarly third stage. In the first stage, it says delay admission till the active stage. That means admit only at 5 centimeters. So the new definition of active stage of labor is now at 5 centimeters. Before it was 4 centimeters, now it is 5 centimeters. So the WHO says don't admit in the labor room till she is 5 centimeter. Don't routinely do a clinical pelvimetry and say, oh, this pelvis is small, she can't deliver. Let the baby decide. So the best pelvimeter of a pelvis, the best way to assess the pelvis, the adequacy, is the baby itself. Okay. Routine CTG is not recommended. Routine perineal shaving is not recommended. Routine enema is not recommended. Do a PV every 4 hours. Analgesia is recommended. So keep the woman pain-free as possible. Make her comfortable. Okay. Encourage movement. Also give her 1:1 care. Allow one person to be with her. Allow her to move around. Don't restrict food or fluids. Let her be hydrated. Don't starve her. Okay. And don't do any of these routine medications or procedures unless they are indicated. So don't do a routine ARM, don't start oxytocin, don't give antispasmodics which cause cervical dilatation, don't give IV fluids unless they are actually indicated. So this is the first stage of labor, what you should do, what you shouldn't do. In the second stage, remember, very important, allow the woman to choose the birthing position of her choice. It's not lithotomy, it's not dorsal, it's not squatting, it's not standing. Let her decide how she's comfortable to push in. Follow the urge to push. Don't tell her when to push. She will, when she gets the urge, she will push herself. So encourage following her urge to push. How do you prevent perineal trauma? This question has been asked now twice in the last 2 years. One is you can put a warm compress on the perineum. Second is good perineal support. And third is perineal massage. These three techniques are going to prevent perineal tears. A routine episiotomy is not going to prevent a perineal tear. It is not to be done. Only restricted use of episiotomy should be done. Fundal pressure going on top and pushing the baby out is again not recommended. In the third stage, and we'll be discussing this in more detail in a bit, is active management of third stage of labor, or AMTSL. What is AMTSL? Active management of third stage of labor. Here, what do we do? Here, we give prophylactic uterotonics should be given. And the uterotonic of choice is oxytocin, 10 units intramuscular. Delayed cord clamping should be done. This is to prevent neonatal anemia. Controlled cord traction by Brandt Andrews technique should be done. And if the woman has received oxytocin, you don't need to massage the uterus. You just have to increase the postpartum vigilance. Check if the uterus is contracted. If it's not contracted, then only massage the uterus. Sabko massage nahi karna hai. Only if it is not contracted, then you massage the uterus. So let's talk more about this AMTSL, because this is again a must know. It is a definitely asked area in the exam because it's so important. First of all, why was this introduced by the WHO in the early 2000s? Was to prevent atonic PPH. And when it was introduced, and it was also implemented by the government of India, and the government of India has not changed since then, these three are the things. First is give oxytocin, 10 units IM. So give a uterotonic, preferably oxytocin. Do controlled cord traction and do uterine massage in this order. Remember it in this order. As soon as the baby is out, give oxytocin, placenta, controlled cord traction, take the placenta out, and then massage the uterus. Before this, you can add one step. So step 0 is actually check for the presence of another fetus. Because if it's a multiple pregnancy which was not diagnosed antepartum, you should not give a uterotonic till the second baby is also out. And the government of India clearly mentions this as the first point in AMTSL. So these are the 4 points in AMTSL. If you go by WHO, these are the 3 points. These are the 4 points for the government of India. Okay. Now, once this is done, then this was found to reduce the incidence of atonic PPH considerably. But some changes were later made. In 2012, the WHO came out with a refocused approach. What did they say? The first point was the same. Give oxytocin 10 units intramuscular. They added a new step here. They have added now here delayed cord clamping was added. Okay, additionally. This is not going to prevent atonic PPH, but it was added to utilize this opportunity to not miss this opportunity to prevent neonatal anemia. So this was an added point. Okay. Then they said only in the presence of a skilled birth attendant are you going to do controlled contraction, because it was found that uterine inversions were increasing. So do it only if required, and do it only in the presence of a skilled birth attendant. Then they said uterine massage sabko nahi karna hai, do only increase the vigilance. If the uterus is flabby, then you do the massage. And it also said to check and make sure that the cold chain supply of oxytocin is being maintained, because oxytocin should be stored in the fridge at 2 to 8 degrees Celsius. If it's not being maintained, then it will affect the efficacy of the drug. Then in 2018, another document came which talked about other drugs that can be used other than oxytocin. It still emphasized that oxytocin was the drug of choice. Okay, and 10 units international intramuscular is the drug of choice. But other than that, it said you can use carbetocin. Carbetocin is important to remember because it's come in the exam. Also, it's a heat stable analog of oxytocin. That means it doesn't need to be stored in the cold chain or the refrigerator. It can be kept at room temperature. And it's given a dose of 100 microgram IM or IV. This was asked, the dose was asked. And remember, it's only recommended till today. That means 2024, it's been recommended only for prevention. It may very soon be recommended for treatment of PPH also. Misoprostol 400 to 600 microgram oral tablet was recommended in areas where you don't have somebody to give an injection. You can give the tablet orally for prevention of PPH. Methergin can also be given, but two important contraindications of methergin are heart disease and hypertension. And you can also, in some areas of the world, you have this combination of oxytocin plus methergin, which you can also give. So these are the other drugs that the WHO said you can use other than oxytocin for AMTSL. Now going a bit further, talking about placental separation. There are 4 signs to know that the placenta has separated. And once you know the placenta has separated, then you do this maneuver called the controlled contraction or the Brandt-Andrews technique. Now what are the signs of placental separation? You'll see a sudden gush of blood. The umbilical cord will appear to lengthen because the placenta has come down. There will be a suprapubic bulge, which is nothing but the contracted uterus. And when you do a PV, you will feel the placenta in the vagina. When you see all these, you simply, in rotating movements, you pull on the cord, and on the other hand, will give counter traction so that the uterus doesn't undergo inversion. This is called a Brandt-Andrews technique. Then we have the 4th stage of labor, where the uterine tone is assessed. Antibiotics for routine uncomplicated delivery are not recommended. Routine postpartum assessment has to be done, and discharge the mother and baby after 24 hours. Now coming to partogram, and this has also changed over the years. As recent as NEET PG 2023, they asked questions on the old partograph. So the old partograph is the WHO modified partograph, and this is because they would have questions in the question bank on this old partograph. But remember, in 2018, the new partograph came, which is now called the Labor Care Guide. So both you should know, because you can get questions from either one. The old partograph, I won't go through the entire thing, but remember the main part of the old partograph, the WHO modified partograph, was this cervicogram. This is called a cervicogram. Okay, where cervical dilatation is plotted against time. This is time, this is cervical dilatation. Okay, and you have 2 lines on this. You have an alert line, which is plotted at the rate of 1 centimeters per hour, and 4 hours to the right of the alert line, you have an action line. The alert line is telling you that you have to be alert. If cervical dilation is going slow and it crosses the alert line, you have to be alert, take remedial measures, see what's wrong. But if it crosses the action line, you have to deliver that baby immediately. Okay, so this is what this means. So a few more important points you should remember. The first plot should always be on the alert line. That is important to understand. Okay, and each small square is half an hour, 30 minutes, and each big square is 1 hour. Okay, so let's just do some examples so you understand better. A 22-year-old primary presents to the labor room at 38 weeks in labor. On examination at 2 p.m., she is 5 centimeters dilated. So at 2 p.m., she is 5 centimeters. The first plotting is always on the alert line. Okay, also remember this WHO modified partograph follows the active labor starts at 4 centimeters. The labor care guide follows that active labor starts at 5 centimeters. So it will be specified what they're asking. But if nothing is specified, remember the new, it's now been 6 years. 5 centimeter is the new active phase. But if we're following this partograph, we will follow 4 centimeters. So she is 5 centimeters dilated at 2 p.m. Remember, the first plotting is always on the alert line. So she is 5 centimeters at 2 p.m. Right? And the head is 3/5 palpable. So this is the descent of the head. This one, 5, 4, 3, 2, 1. These ones are taken as descent of the head. So she was 3/5 palpable. I will mark it here. After 4 hours, she is fully dilated. So 2, 3, 4, 5, 6. She is fully dilated after 4 hours. So this is the plotting. Okay, so this is how she has dilated. She has dilated very well. Okay, so the alert line is 1 centimeters per hour. If she is dilating faster than that, it will come to the left of the alert line. So you're not worried if anything is on the left of the alert line. Anything which is in this region, you become worried, you become alert. Anything on this side, you have to take action. Okay. Let's see another example. A 30-year-old G2P1L1 is induced for past dates at 40 weeks, 4 days. After 6 hours, she is examined and found to be 4 centimeters. So at 1 p.m., she is 4 centimeters. At 5 p.m., she is 6 centimeters. So 1, 2, 3, 4, 5. You find she is only 6 centimeters. So what has happened? She has now crossed the alert line. So you have now to be alerted. So what was done? An ARM was done. So probably contractions were less. To augment labor, an ARM would have been done. Oxytocin might have been started. Okay, so here an ARM was done. Okay, and at 8 p.m. she is fully dilated. So 6, 7, 8. So can you see she has again resumed the 1 centimeter per hour trend at which she should actually dilate. So this is how you plot the partograph. And one more example, a 24-year-old primary presents at 39 weeks in labor. At 6 a.m. she is 4 centimeters. So this is 6 a.m. After 4 hours, she is found to be dehydrated. Contractions are good. See, 4 in 10 minutes lasting to 40 to 45 seconds means there is not a problem in contractions. She is getting very good contractions. But on PV, she is still 4 centimeters. So 6, 7, 8, 9, 10. She is still 4. So this is called as arrest of dilatation. It's not slow dilatation. It's actually arrest. She hasn't progressed at all despite the uterine contractions being very good. And see what is happening. Molding is now 2+. So what is your diagnosis? This woman has gone into or is going into obstructed labor and she needs to be delivered immediately. She's reached the action line and she's only 4 centimeters. So what will you do? You will deliver her by a cesarean section. Okay, so this is the WHO modified partograph and how you should do the examples. Now, however, we have the LCG or the labor care guide, also called the next generation partograph. This is how it looks like. If you want to know in more detail, go through the main videos. Okay, because it's never been asked till now. Till now, the only thing we've asked is that it starts at 5 centimeters. But you should know more and more because you never know when they will suddenly ask a question on this. Why were the changes made? Because it was found a lot of unnecessary interventions were being done. Okay, and hence the rate of cesarean sections were increasing. So that's why it was changed. Also, had the new definition of active labor became 5 centimeters. So hence it had to be changed. So remember that it has 7 columns which have to be marked. Section 1, Section 2, Section 3, Section 4, 5, 6, 7. In this, remember, this is a new column. Supportive care was never there before. And shared decision making, that means what actions have you taken, was never there before. So these are the two new sections. Also remember, labor progress has changed completely. There is no alert line, there is no action line, there is no 1 centimeters per hour. All that has changed. Okay. For whom should the LCG be used? All women in labor it should be used, but high risk women require additional monitoring. When should we start using it? At 5 centimeters or more. And in which settings should we use it? In all hospitals, big hospitals, small hospitals, all levels of care, you should be using the LCJ. This is a table showing the difference between both. So in modified partograph, we start at 4 centimeters. Here we start at 5 centimeters. In modified partograph, you had the alert line, the action line. Here we don't have that. Here we have proof-based time restrictions at each centimeters. Okay. There was no second stage here. Here there is a second stage monitoring. There was no documentation of what you're doing. There was no supportive care. Here you have companionship, pain relief, fluid intake, posture. All these are recorded because they have been found to make a difference in the progress of labor. Here the main focus was cervical dilatation. Here there is focus on everything. It's not just limited to see how the cervix is dilating. Everything is taken into account and the findings are recorded and the plan of action is taken. So that was about normal labor. Now we move on to abnormal labor topics. So we now move on to abnormal labor and we start with occipito-posterior position. Now this is a position where the occiput faces backwards and hence the back of the baby also will be towards the back of the mother. Now in occipito-posterior position, one of the important questions that came recently was the diagnosis on clinical examination. So when you examine a patient with occipito-posterior clinically, what you find is that the abdomen, the patient's abdomen won't be rounded like this. Okay, there will be a subumbilical flattening. So normally a pregnant woman's abdomen will appear like this, right? But in occipito-posterior, what you find is that it is something like this. It's got a subumbilical flattening. Okay, and this is because the back, which should be here, which makes the abdomen well rounded, is posterior. So you have a typical, this is a buzzword to remember this, subumbilical flattening. If you see, it's talking about occipito-posterior. Other typical features on examination would be that the fetal heart will be best heard towards the flanks, पीछे की तरफ, behind. Okay, so the fetal heart is best heard at the flanks. Also, this is a woman who's going to have premature bearing down when she goes into labor because the back of the baby, the occiput is pressing on the rectum. So she'll have this urge to push much before she's actually fully dilated. So these are typical findings on clinical examination in occipito-posterior. Also remember, occipito-posterior is typically associated with an anthropoid pelvis. We have discussed this, but this has come as a question almost 3-4 times in the past few years. Okay. Now, the important aspect to occipito-posterior is what is going to happen during the mechanism of labor. Now, during mechanism of labor, remember 4 things can happen in occipito-posterior. So, here you have an occipito-posterior. You can see the occiput is posterior. This is occipito-posterior. The most common thing to happen 90% of the times is during mechanism of labor, that is engagement, then flexion, descent, then flexion, then internal rotation. Remember what I told you, LOA to OA, 45 degree. But here it's ROP to OA. How much degrees will this going to turn? This is going to turn by 135 degrees anteriorly. So the occiput now becomes anterior. This long arc rotation, okay, is what most commonly happens in the mechanism of labor in 90% of patients with occipito-posterior. So labor is a little prolonged. Internal rotation is much more, it's 3/8 of a circle. So this is called long arc rotation. And then from here, this will deliver like a occipito-anterior baby. In less than 10% or around 7 to 8% patients, what happens that a short arc rotation happens. That means internal rotation happens, but by 45 degree in the opposite direction. So the occiput is now facing posteriorly, and this becomes a direct occipito-posterior position, and this baby is going to be delivered by something called face to pubis delivery. Face to pubis delivery is because the face is going to come out facing the pubic symphysis, and the problem with this kind of delivery is that there's a higher incidence of perineal tears. Okay, so because the perineum is descended by a much wider diameter, so higher incidence of perineal tears should be anticipated if you're having an occipito-posterior, direct occipito-posterior delivery. In a much smaller percentage, what's going to happen is that the baby starts moving along the long archway, but after 45 degrees, it gets arrested in the transverse plane. So the occiput The sagittal suture is stuck in the transverse plane of the pelvis at the level of the ischial spine. That means at zero station, and this is called as deep transverse arrest. And then even fewer percentage, what happens? Nothing happens. It remains as such. This is called as persistent occipito-posterior. So, long arc rotation, short arc rotation, deep transverse arrest, and persistent occipito-posterior are the different possibilities that can happen in the mechanism of labor of occipito-posterior. Okay. Now, special emphasis on deep transverse arrest, because this scenario can come as a question. It has come as a question. It is when there is, despite good uterine contractions, despite full cervical dilatation, the head gets stuck at the level of the ischial spines with the sagittal suture in the transverse diameter of the pelvis. Okay. Now, what do you do in such a scenario? In such a scenario, you have to first see if there are signs of obstruction. If there are signs of obstruction, that means if your question says patient is dehydrated, caput is plus plus or plus plus plus, molding is plus, what will you do? Then you will do a cesarean section. Okay, and this is usually the scenario in a primigravida. Primigravidas, that means the pelvis has never been tested before. This is most likely an android pelvis. That's why this has happened. So, cesarean section. Multigravida with no features of obstruction. So, multigravida with obstruction, again cesarean. But if this is a multi and there are no features of obstruction, no features of obstructed labor, then you can attempt a vacuum delivery. Zero station is too high for a forceps, but a vacuum delivery may be attempted if there are no features of obstruction. In olden days, rotational forceps would have been tried, but we no longer use them. We would prefer, if any instrument, a vacuum, that only if there are no features of obstructed labor. Okay. Now coming to face and brow, small things about face presentation. This is complete extension. The diameter is submentobrachmatic. What happens when you're examining this patient on abdominal examination? Remember, the back is difficult to feel. Okay, the limbs are more prominent. If the baby is in mento anterior, you can feel the limbs more prominently. In the second pelvic, remember by the second pelvic rib where you're facing the mother, you find that the head is not engaged usually, and you find that the occiput, this is the occiput, is at a higher level than the sinciput. Okay, normally what happens, the occiput is at a lower level in a fully flexed head, but here you're finding the occiput is at a higher level. How do you know which side is the occiput, which is the sinciput? Whichever side the back is, that the occiput is going to be on that side. Okay, and also when you examine, you will find this groove structure present on abdominal examination. So, you will find a groove felt, and on vaginal examination, you can very commonly confuse this with a breech. Why? Because when you do a PV, the mouth, the sucking action of the mouth, the baby might start sucking your finger. This can feel like you're inside the anus. Okay, and secondly, the malar prominences which you feel here, the malar prominences may feel like the ischial tuberosities. How do you differentiate this between face and brow? Remember, this is going to form a triangle, the mouth and the two malar prominences. But in this is going to be a straight line. The two ischial tuberosities of the baby and the anus is going to be in a straight line. So that's how you differentiate breech from face on a vaginal examination. Okay. Also remember, if it's mento anterior, then the head is borne by flexion. Vaginal delivery is possible and the head is borne by flexion. But in mento posterior, there is no mechanism of labor. So there is no mechanism of labor. That means she can't deliver vaginally in brow, in mento posterior, and in transverse lie. Okay. Next is brow presentation. Brow presentation is very similar. Here you have the denominator is the frontum. The diameter, anterior-posterior diameter, is the mento-vertical or vertico-mental, which is 14 centimeter, which is too big for any diameter in the pelvis. And hence treatment is, or what is the management? How will you manage this? If brow remains brow, no extension or flexion is happening, this patient will have to be delivered by a cesarean section. There is no mechanism of labor. Another short topic is shoulder dystocia. What is shoulder dystocia? When the head comes out, okay, the head is out, but the shoulders fail to deliver. In fact, they get stuck and they tend to bring the head recedes back inside. what is called as a turtle sign. The turtle comes out of its shell and then it goes back inside. This is called a turtle sign. Very important. Okay. Now, one definition and a more objective definition, if there is a 1 minute lag between delivery of head and shoulders, it is called as shoulder dystocia. Okay, another definition, a more practical definition, is if the shoulders require maneuvers to be brought out, it is shoulder dystocia. Now, this is very important. Questions come from here. The management or the shoulder dystocia drill, whenever you're in the labor room posted there, we all go through this drill, which is called the helper mnemonic. It's, remember, by the name, by the mnemonic helper. H is for calling for help. Call everybody, a senior person preferably should be around to help you out. Episiotomy, if you've not given episiotomy, give. If you have given it, extend it. It gives you more space to perform the maneuvers. And the most important maneuver that you're going to do, which is going to resolve 90% of all your stuck shoulders, is the Mac-Roberts maneuver. What is this? This is Mac-Roberts. It is hyperflexion and abduction of the hip on the maternal abdomen. This is going to resolve 90%. Doing this maneuver pushes the sacrum back, pushes the pubic symphysis in front, and dislodges most of the impacted shoulders. So Mac-Roberts, most important first maneuver to be done is Mac-Roberts. If Mac-Roberts fails, is suprapubic pressure is the next maneuver, and these are the first line maneuvers. Okay, suprapubic pressure is done like this in a CPR fashion, or from the top, like this woman is doing. Okay, she's pushing from the side of the back and trying to dislodge this anterior shoulder. Usually, in fact, both are done together, Mac-Roberts plus this pushing. But if you have to go in proper order, it is Mac-Roberts first and Mac-Roberts most important, and then suprapubic pressure. So these are the first line maneuvers: HELP, episiotomy, Mac-Roberts, and suprapubic pressure. The second line maneuvers are then done if the first line maneuvers fail. What are the second line maneuvers? You enter, the first is E. E is enter the rotational maneuvers. Here you have two. One is the Rubens maneuver and the second is the wood screw or wood's corkscrew maneuver. You don't really need to know what they are, but just for sake of telling you, this is the Rubens maneuver. You put your hand behind the posterior part of the anterior shoulder and adduct the arm. Try to bring it towards the chest. This will reduce the biacromial diameter and the shoulder gets dislodged. If this fails, you continue turning this baby by 180 degrees like this. Here they've shown from the posterior shoulder. So you rotate this by 180 degrees and this will dislodge the posterior arm, or depending which arm you're doing first. So this is the Wood's corkscrew maneuver. Now, if this fails, so we had helper, this was first line, and then we have second line. This was rotational. Enter the rotational maneuver, Rubin and Wood's corkscrew. Then you have the first R. The first R is removing the posterior shoulder. Okay, so this is actually removing the posterior shoulder. Here you can put your hand in, okay, and you just pinch on the fossa here. This will bend and the cubital fossa will bend, and you can try to grab the baby's hand and bring out the posterior shoulder. So this is another second line maneuver. So E is enter the rotational maneuvers, R is removing the posterior arm, and the last R is roll the patient on all fours, which is called the Gaskin maneuver. Roll on all fours. Okay, and by doing this and then repeating the maneuvers again in this position, many times the baby gets dislodged, because this gives an additional space of 1 centimeter more to roll on all fours. And if all this fails, then enter the third line maneuvers. And here you have 3, the Zavanelli. Zavanelli means you push the baby's head back in and take the baby out by cesarean section. Or you can do a fracture of the clavicle, which is called a cleidotomy, deliberate fracturing of the baby's clavicle. Or you take a scalpel and cut the pubic symphysis of the mother after giving local anesthesia. This is called a symphysiotomy. This will also dislodge, because the pubic symphysis breaks apart, the shoulder gets dislodged. So just a quick revision, because it's very important. We have the helper mnemonic, where the first line maneuvers are HELP, call for help, episiotomy, legs or Mac-Roberts, and suprapubic pressure. Then you have the second line, which is enter the rotational, where you have Rubin and Wood, then remove the posterior arm, then roll on all fours. Then you have the third line, Zavanelli, cleidotomy, and symphysiotomy. Okay, so remember this mnemonic, the helper, and then the third line maneuvers. Also remember which woman at a higher risk of developing shoulder dystocia. Women who have GDM, their babies tend to be macrosomic. In fact, if a woman who is GDM, gestational diabetes mellitus, if the baby weight is more than 4.5 kg on ultrasound, the estimated weight, this patient should be having an elective LSCS. Normally, we advise elective LSCS if the baby weight is more than 5 kg, but in GDM mothers, we advise elective LSCS after 4.5 kg to prevent shoulder dystocia. If there's a previous history of shoulder dystocia, if the woman is obese, if the forceps or vacuum have been used, then this baby is more likely to get stuck. So remember this, macrosomic babies, especially mothers of GDM, previous history of shoulder dystocia, obese mothers, and forceps and vacuum. The next malpresentation, very important, is breech presentation. A lot of questions come from here. The most common reason for breech is a preterm baby. At 28 weeks, 25% of all mothers will have their babies in breech presentation. Okay, and this incidence reduces to 3% at 37 weeks. So at term only 3% remain, but the most common cause is preterm. There are many other causes: multiple pregnancy, oligohydramnios, polyhydramnios, Mullerian anomalies, fetal anomalies, short cord, many other reasons. Okay. How will you diagnose this? On examination, of course, the Leopold maneuvers. On the fundal grip, you will find the head. On the pelvic grips, you will find the breech. Okay, but you will confirm this by an ultrasound. And ultrasound will also tell you if there's a reason for the breech. Is there placenta previa? Is there multiple pregnancies? Is there oligohydramnios? Is there polyhydramnios? It will also tell you the type of breech, so you can plan delivery accordingly. Okay, so what are the different types of breech we have? So we have the first one. Look at the first one. There is flexion at the hip and extension at the knee. This is called an extended or a frank breech. Okay, then you have a complete or a flexed breech where there is flexion at the hip and flexion at the knee. Then you have extension at the hip and extension at the knee. This is a footling where the foot is the presenting part. You have extension at the hip and flexion at the knee. This is a kneeling where the knee is the presenting part. These are the more common ones. These are quite rare. Okay, so the extended and complete breech are more common. Now, how do you manage breech, especially at term? Our main worry is how do we deliver this baby? Because if we allow for a vaginal delivery, there is a very high risk of the head getting stuck. So you don't want a hypoxic baby, but you also don't want to unnecessarily do a cesarean section, right? What's the first thing you can think of? The first thing you can think of is, can I turn this baby? And that is called as external cephalic version. Okay, and very commonly asked because ECV is one of the methods that is known to reduce the incidence of unwanted cesarean sections. So ECV can be tried between 36 to 37 weeks is the ideal time. You can even try it beyond, but the ideal time is at this time. It is not done too early because if there's a complication, then you're taking out a preterm baby, and also it can revert back to breech if you do it too early. You don't do it too late because the baby becomes bigger, the liquor dries up, it becomes difficult to do it. So this is the ideal time. Okay, also remember it has a 60% success rate. Okay, and it should be the first thing that is offered to all mothers with breech when they come at this period of gestation, unless there is a contraindication. What are the contraindications to ECV? The main contraindication is your end aim of doing an ECV is to achieve a vaginal delivery. If you're not going to be able to do that, then there's no point doing the ECV, right? So, for example, in placenta previa, contracted pelvis, there's no point because even after you do the ECV, you're going to do a cesarean section. So, you're just simply putting the mother at risk. There's no point doing it. Multiple pregnancy for both the babies, no point. ECV has a role in multiple pregnancy where after delivery of the first twin, but I'm talking about antepartum period. Hyperextended head or a star-gazing fetus. In fact, a star-gazing fetus becomes a direct indication for doing a cesarean section because the head is extended, you can't turn it, She can't deliver vaginally because the head will get stuck. So it's a direct indication for a cesarean section. And a Mullerian anomaly is, or even a fetal anomaly for that matter, is an absolute contraindication to doing an ECV because the space is less. Okay, and if the baby is dead, distressed, or the patient denies consent, okay, because a dead baby, it doesn't matter now. You're not worried about the head getting stuck. The baby is anyway dead. You can allow her for a vaginal delivery. Baby who is distressed, you would take that baby out quickly by a cesarean section. So mother doesn't give consent, then you don't have any choice. Okay, so ECV is the primary management. If you can't do this, or there's a contraindication, or the patient doesn't give consent, then we have to decide what to do next. What are the factors that will favor a successful ECV? If she is multiparous because the abdomen is more lax, it's not very tight. If the presenting part has not entered the pelvis, if the liquor is good, and if the placenta is posterior, that helps. If it's anterior, it will obstruct your maneuver. Okay, so this is what's going to favor a successful ECV. Now, suppose ECV fails or the patient doesn't give consent. Okay, then what do you do? Okay, then you have two choices. Either I can deliver this baby vaginally, what is called an assisted breech delivery, or I plan an elective cesarean section. What helps me decide what to do or how to do this next is by the Zatuchny-Andros scoring. This is a scoring which has 6 parameters: the parity, the gestational age, the fetal weight, previous breech if she's had, cervical dilatation, and station of the breech. A higher score, so a score which is high, a score which is in fact more than 3, is favorable for a vaginal delivery. You can attempt or counsel the patient for a vaginal delivery. That means in a multigravida, somebody who is a more preterm, okay, whose weight is lesser weight, who has had 2 or more previous breech deliveries, who is very much in labor 4 centimeters or more, and whose station is low down. Any of these gets a much more favorable scoring than a primey, os closed, big baby. Okay, so this will sort of help you determine what would be your mode of delivery. Okay, also remember factors against a vaginal delivery, or factors, in simple words, factors favoring a cesarean section are what? Are a primigravida who is very preterm, who is more than 3.5 kg baby, who has a stargazing fetus, who has a complicated breech. What is complicated breech? Complicated breech, remember, is breech plus any other complication in pregnancy, like breech plus preeclampsia or breech plus gestational diabetes mellitus. So breech plus any other thing, don't risk it, do a cesarean section. Previous cesarean, remember, previous cesarean is not a contraindication for ECV. If the patient has a previous lower segment cesarean section, you can do an ECV. Okay, but if she's had if your ECV has failed, then it's better to do a cesarean, to do a repeat cesarean. Don't allow her to have a vaginal delivery. If you don't have anybody who knows how to do a breech delivery, there's no point allowing her to have a vaginal breech delivery. Or if it's a footling or kneeling breech, again, don't try a vaginal delivery. Now, so there are 3 types of vaginal deliveries. One is total breech extraction. This is usually done under anesthesia and usually done the second of twin along with internal podalic version. Here you put your hand inside the cervix, grab the foot of the baby and take the baby out. Everything you're doing. Okay, so this is done very exceptional circumstances under general anesthesia in the second of twin who is in transverse lie along with internal podalic version. The second type of breech delivery is assisted breech delivery. This is the one which most of us talk about. Different maneuvers are there. In this, to some extent, we help, especially the aftercoming head of the baby, we help deliver. And the third is a spontaneous breech delivery. So these are breech deliveries where no help is required. The baby comes out by itself. No additional help is required. This is even very, very small, very early preterm deliveries, 28 weeks, 30 weeks. No additional assistance is required. The head doesn't get stuck. Now, some important maneuvers you should know in assisted breech delivery, because they come very often as images. Sometimes the arms are like this. What do you do, or what maneuver helps release them, is the love set maneuver. It is turning the baby by 90 degrees and then by 180 degrees. So this helps release the overhead arms. Then you have after coming head. So what is this maneuver? This is a Burns-Marshall technique. It is not that commonly done nowadays, okay, because there is a higher incidence of trauma at the atlanto-occipital or the cervical spine with this maneuver. Instead, we prefer a more controlled delivery, that is the Morisot-Smalley-Viet or the MSV technique, where there is occipital flexion from this end and malar traction. So flexion of the head is happening in a more controlled fashion, and suprapubic pressure helps in maintaining this flexion. And another very good way, in fact, the better way, the one which reduces the risk of trauma to this head, is the use of Piper's forceps. It allows the head to come out in a more controlled fashion, reduces pressure on the atlanto-occipital joint, avoids a sudden compression, decompression of the intracranial pressure, and hence reduces the incidence of birth trauma, that is using a Piper's forceps. Now another small topic which is very similar is transverse lie, and then we move on to cord prolapse. What is transverse lie? This is a baby in transverse lie. Okay, so when the shoulder is the presentation, okay, again similar etiology to breech presentation, why it happens. And what can you do? Can this deliver vaginally? There is no mechanism of labor. Okay, and if you allow labor to happen, contractions set in, what's going to happen? Membranes are going to rupture, and if membranes rupture, cord can prolapse out. Okay, and the hand can also prolapse out. So the problems you have with transverse lie are cord prolapse and hand prolapse. Now if the hand prolapses out, you're going to have something called a neglected shoulder presentation. This is not shoulder dystocia. This is neglected shoulder, where the shoulder is stuck. It's impacted here. And can you see what's happening? The upper segment is contracting. The lower segment is thinning out. This is what is formed in the middle is Bandel's ring has formed in the middle. Eventually, this is going to rupture. Okay, so this is what happens with transverse lie. If she's allowed to go into labor, cord prolapse and obstructed labor with hand prolapse is going to happen. So what do you do? Again, if you diagnose this early, around 36 to 37 weeks, and if there is no contraindication, external cephalic version can be done here also. Okay. Or if she's not willing, or if it fails, or if she comes late, then you plan an elective LSCS at 37 weeks of gestation. Okay. So you can do an external cephalic version, or you plan elective LSCS at 37 weeks. Now again, a very important topic, recent times it's being asked very, very commonly, is cord prolapse. What is cord prolapse? Cord prolapse is when the cord comes outside the introitus, like here, okay. This is called as cord prolapse. When cord prolapse happens, what happens? This cord gets compressed between the fetal parts and the maternal parts, and this leads to acute fetal hypoxia. And if you don't take the baby out in 15 minutes, it's going to lead to fetal death. Okay, so if this happens in front of you, you have to immediately rush this patient for a cesarean section. Two more terminologies you should know is cord presentation. What is cord presentation? Or one more terminology you should know is cord presentation. This is when the membranes are intact. Okay, that means the membranes haven't ruptured. But as soon as it ruptures, the cord is going to come out. So this can be diagnosed on ultrasound routinely at term. If you do a scan and if you see the cord lying below the fetal head, you should immediately plan a cesarean section for her at 37 weeks as soon as she goes into labor. Otherwise, and the membranes rupture, the cord will come out. Or when this patient comes in labor and you're examining her, you do a PV, and through the bag of membrane, say she's 3 centimeters, 4 centimeters, 5 centimeters dilated, when you do a PV, through the PV, you can feel the cord, and this cord is felt as a bag of worms. So if you feel this bag of worms, you know that the cord is presenting, it's a cord presentation. As soon as membranes rupture, you'll end up with a cord prolapse. So in a cord presentation, the treatment is an elective LSCS at 37 weeks. So before cord prolapse has happened, you have found this. Okay. But if cord prolapse has happened, what is your diagnosis going to be? You're going to be a patient in labor who has sudden fetal bradycardia, or the fetal heart disappears. This is how it's going to present. When you see her, you find the cord lying outside the introitus. What do you do? Immediately, what do you do? Immediately, you're going to relieve the pressure of the cord. So basically, when it comes to management, first is of course confirm if the baby is dead or alive. If the baby is dead, then you can't, there's no point expediting delivery, right? But if the baby is alive, and this usually happens if it's happening right in front of you, okay, primary aim is to deliver the fetus, and while you are getting arrangements done to deliver the fetus, you will do something. You will try to relieve pressure of the cord, push the presenting part away from the cord, make her lie on in a head low position. Different ways are there. So how can you relieve the pressure on the cord? First is fill the bladder. A full bladder is going to lift the presenting part away from the cord. Second is manually with your finger do a PV and push the head or the breech or whatever the part is which is pressing on the cord, lift it away. Third is Trendelenburg. What is Trendelenburg? Make the mother or the table like this. Okay, that is a head low position. A steep head low position is Trendelenburg position. Or again, like in Gaskin maneuver, roll her on all fours, okay, or roll her over on knee chest position. That also relieves the pressure, or just turn her to the side, left lateral. Any of these positions will do. You can also give terbutaline 0.25 milligrams subcutaneous injection. This will stop or minimize the contractions and relieve the pressure of the cord. But under no circumstance are you going to touch the cord or try to reposition the cord, because the moment you handle that cord, it is going to undergo vasospasm. Already it is getting constricted. Vasospasm is going to worsen the whole situation. So don't handle the cord. Okay, now coming to obstructed labor. Obstructed labor is a very small topic, but it's important because here you need to understand what are the features of obstructed labor. So what is obstructed labor? First of all, it is when labor, the progress of labor is arrested due to a mechanical factor. That is usually a big baby or a small pelvis, okay, or some obstruction like say a fibroid in the way. So when this happens and the patient goes into arrested labor, this is going to happen. Now imagine a uterus contracting and the baby is unable to come out. What's going to eventually happen? Usually in a primigravida, the uterus is going to go into a state of uterine inertia. And in a multi, what is going to happen? In a multi, this is going to rupture. The uterus can rupture. Now, important, the question that comes from here is how will you diagnose, or how do you know what situation is there? Because if you have encountered obstructed labor, even if the baby is dead, the treatment is an emergency cesarean section. Okay, so you need to be able to identify the features of obstructed labor in a clinical question. So what happens? You find that the upper segment is contracted and thick. The lower segment also becomes thinned out, distended and thinned out. And in between both the upper segment and lower segment, you find what is called as Bandel's ring or ring of retraction. Okay, between the upper segment and lower segment. And if the obstruction doesn't get relieved, the Bandel's ring moves upwards towards the patient's upper body. It keeps moving up because the lower segment keeps getting more and more thinned out. Okay, fetal parts won't be easily felt because the uterus is in a state of continuous contraction, and the fetal heart rate usually the baby may be distressed, or the fetal heart may actually be absent. This patient also will be very, very dehydrated, will have a ketotic, acidotic breath. Okay, and when you do a vaginal examination, you will find a hot and dry vagina. You will find the head is jammed in the pelvis. You'll find the cervix loosely hanging on the side. You may even find features of hematuria because the head is jammed and it is pressing on the bladder. So all these things, if you find, what will you do? You will immediately arrange for an emergency cesarean section, even if the baby is dead. Remember this. Okay. And a very important point to note is that keep the urinary catheter for a prolonged duration, for at least 2 to 3 weeks is the recommendation, because otherwise if you take the catheter within 24 hours, which we usually do, what's going to happen is the bladder is going to fill up, okay, and it's going to the area where the obstruction happened, that bladder area would have undergone ischemic necrosis. So what's going to happen, as soon as the bladder is allowed to fill up, that necrosis ischemic area will give way and a vesico-vaginal fistula can form. So to prevent a VVF, you have to continuously keep the bladder empty and allow time for healing to take place, which usually takes place in 2 to 3 weeks. Okay. Now we move to third stage complications, and in this the most important of course is postpartum hemorrhage. What is postpartum hemorrhage? It is when the bleeding is more than 500 ml following a vaginal delivery, or more than 1000 ml following a cesarean section, although the ACOG now says more than 1000 ml for either of them. But classically, we've always explained this. Following a delivery, this is postpartum hemorrhage. Okay, it is one of the most common causes of mortality the world over, maternal mortality the world over. We have two types. If this is happening within 24 hours of delivery, it is called as primary postpartum hemorrhage. But if this is occurring anywhere after 24 hours till 6 weeks, it is called as secondary postpartum hemorrhage. Okay. And you should know the 4 T's, the causes of primary PPH. The most common, 80%, is because of an atonic uterus. That is, the uterus is failing to contract. It is relaxed. Okay. Other causes could be trauma. That means a laceration, vaginal, vulval hematoma, cervical laceration, even uterine rupture will come under traumatic PPH. Then tissue. Tissue means a retained placental bit has been left inside. And the last is thrombin. That means patient has some coagulation disorder like ITP, or she's gone to DIC. Then we attribute it to thrombin. That means a coagulation disturbance. So tone, trauma, tissue, and thrombin. Of course, the most important is atonic uterus. Now, how do you manage PPH? There's something called the 0-hour checklist. That means immediately what should you do? Call for help. Maintain A, B, C, D, E. What is A, B, C? We know is airway, breathing, circulation. D is disability, and E is exposure. Obtain IV access with 2 wide-bore cannula. Take blood samples for investigations. Catheterize the patient. This is going to help keep the bladder, keep a check on the output. Also, an empty bladder helps the uterus contract better. Calculate the vital signs. See the vital signs and calculate the shock index. Very important possible question in the exam. What is the obstetric shock index? It is the heart rate or the pulse rate divided by the systolic blood pressure. Okay, and a normal shock index in obstetrics is between 0.7 to 0.9. Anything more than 1 is associated with an adverse pregnancy outcome. This is a very, very potential question in the exam. To repeat, what is obstetric shock index? It is the pulse rate divided by the systolic blood pressure. The normal range in pregnancy is between 0.7 to 0.9. Anything going higher up, more than equal to 1, is associated with an adverse clinical outcome. So this table looks confusing. This is from one of the standard guidelines. Let me take you through it. So the one on this side is general for all types of postpartum hemorrhage. We resuscitate, we call for help, we perform bimanual uterine massage. Okay, we institute the labor unit. Every labor unit will have a protocol, institute the protocol. Okay, large IV lines, oxygen by mask, check the vital signs, check lab testing, what we've all discussed. Okay, and aftercare is also described here. Aftercare means once everything is settled, you have to monitor her for ongoing bleeding, assess the signs and symptoms of anemia, and debrief with the patient, the counseling part with your team members, all that. So all that comes in resuscitation and aftercare. Then coming to individual management. So the first one is if the problem is in the tone. If the problem is in the tone, you initiate your uterotonics. What uterotonics can you give? You can give oxytocin, you can give methyl ergometrin, okay, you can give carbetocin. But remember, carbetocin, I am not putting here, carbetocin is recommended till the class until the time I'm taking the class today, that is 2024, it is only recommended for prophylaxis by the WHO of PPH and not yet recommended for treatment of atonic PPH. Okay, misoprostol can also be given and PGF2 alpha. So oxytocin, PGF2 alpha, methergin and misoprostol are the drugs we give as uterotonics for atonic PPH. Then we have trauma. In trauma, what will you do? You'll suture the laceration. If it's a hematoma, drain the hematoma. If it's an inversion, correct the inversion. If it's a something requiring a laparotomy like a rupture, repair the rupture or do a hysterectomy. If it's tissue, what will you do? You will explore the uterus, do a manual removal, might require a gentle curettage. Okay, so that has to be done. And if it's a thrombin, then you have to correct the coagulation disturbance. Okay. Also remember, tranexamic acid, which has been recently recommended by the WHO, can be given within 3 hours of bleeding happening. 1 gram IV is given and a second dose can be repeated within 30 minutes. Also remember, mechanical methods, especially if it's atonic PPH, mechanical methods like balloon tamponade, okay, even uterine artery embolization can be considered. Suction cannula, this is something new. So the JADA system by the Americans and the Panicker cannula by the Indians are suction cannula which can be put in the uterus, suction created and the uterus contracts over the suction cannula. These can also be done. Okay, so these are different. There are even transvaginal uterine artery clamps which have been devised by very famous Indian obstetrician gynecologists. So different mechanical methods also at the same time should be initiated. These are the different drugs which can be used. This is too smaller table to see, so I have individually put them. Oxytocin. Okay, this dosage is for prophylaxis, that is active management of third stage of labor. For actual treatment of PPH, you can go even up till 40 international units as an IV infusion. Okay, remember that the onset of action is very fast and these are not very important. Okay, but this obstructed labor and grand multipara is contraindication when you're using it in labor, not once the patient has delivered. Methyl ergometrin, we've discussed this. Hypertension, cardiac disease are the contraindications. Prostaglandin F2 alpha can be given 250 microgram intramuscular. It is not to be given in a woman who has bronchial asthma. And misoprostol can be given 800 to 1000 microgram rectally or 600 to 800 milligrams sublingually or orally. Okay, and it is a very beneficial method when you have you're sitting in a low resource setting with not much with nobody to give an injectable drug. Carbetocin we have discussed, but this is given for prophylaxis, active management of third stage of labor and not for treatment as of now. Now, these are the mechanical options we have. So, along with medical management of atonic PPH, mechanical usually goes hand in hand. What are we doing here? This is a bimanual compression being done. Okay, these basically act as temporary methods till the time the medical method starts acting or till the time you're transferring a patient for a more definitive method. What are these? These are intrauterine balloon tamponades. The most common one and the one specifically designed for this purpose is the Bakri tube. Okay, and all of them are to be inflated with 300 to 500 ml of saline, okay, to achieve good distension for the bleeding to stop. So you can even use Sengstaken Blackmore tube. This is a Rouge catheter. This is a condom catheter which has been fashioned into a mechanical intrauterine tamponade. This is the non-pneumatic anti-shock garment. Okay, and this has been devised again or recommended by the WHO in rural areas when transferring a patient with PPH to a higher center. Wrap her in this garment. This is external aortic compression, again temporary measure to reduce the blood flow to the uterus. Now, if all these fail, okay, and one newer thing I told you nowadays which is being used is intrauterine suction cannulae. These also are now being used. Now, if these fail, then you move on to surgical management. Surgical management, you can see this is called a compression suture. The one you're seeing here is the B. Lynch suture. Again, it's useful in atonic postpartum hemorrhage. There are different other sutures. So this is the B-Lynch. It is recommended when there's already a cesarean section scar. Through this, you put the suture. If you don't have a cesarean section scar following normal delivery, we prefer Hayman's or the Cho's square sutures. Another thing you can do is the stepwise devascularization. So devascularize the uterus by ligating. First, we ligate the bilateral uterine arteries. Then we ligate the utero-ovarian anastomoses. And if still the bleeding doesn't stop, then the anterior division of the internal iliac artery can also be ligated right here. So for all of them bilateral, both sides it's done. And this would usually stop the bleeding. If nothing else works, then a direct hysterectomy can also be done. Uterine artery embolization is advised. Usually it's more commonly done when the patient is hemodynamically stable. It can also be a good option in patients who come with secondary postpartum hemorrhage. Now, what does the WHO recommend for treatment of PPH? It recommends that IV oxytocin is the drug of choice. The other drugs which can be used, of course, are misoprostol, methyl ergometrin, okay, PGF2 alpha. Okay, crystalloids is the mainstay of fluid therapy. Till the time blood is transfused, crystalloids should be given. Antifibrinolytic should be given 1 gram IV over 10 minutes within 3 hours of birth and can be repeated in 30 minutes, not 3 hours, can be repeated in 30 minutes. Uterine massage, intrauterine balloon tamponade are temporary measures, and finally surgical treatment if nothing else works. What is this? This is a picture showing uterine inversion. Remember, uterine inversion, although rare, can cause a lot of mortality and morbidity, okay, primarily by causing neurogenic shock, not hemorrhagic shock. Hemorrhagic shock can also happen, but more commonly is neurogenic shock because of stretch of the uterosacral nerve plexus. If this happens in front of you, this is a patient who has come after many hours, she's been come and the whole uterus is edematous. It's not easy to replace this without anesthesia. But if the inversion is happening in front of you, while you are pulling on the cord, sometimes this happens. If you're happening in front of you, what do? You immediately replace the uterus with the placenta still attached. Many times the placenta is still attached. Here it's not shown, but many times the placenta is going to be attached. And while you're doing a controlled cord traction, this is happening. So if this happens with the placenta in situ, push the uterus back inside. Okay, keep your fist inside. Ask your assistant to start oxytocin. Once the uterus starts contracting, then gradually withdraw your hand. Okay, and then do a MRP if the placenta is inside. Okay, so in first replace the uterus, then remove the placenta. Okay, so don't remove the placenta first and then take it back in. Don't shift to OT and then attempt. As soon as it's coming out in front of you, quickly put it back in. Okay, that's the best way to manage this, and this has come as a question. Also remember, the part which comes on first, okay, is the last to go back in. So if the fundus is coming back first, don't replace the fundus back in first. Replace the sides first from here. Okay, and lastly, the fundus will go back in. Sometimes, like if it's grossly edematous like this, it may become difficult to replace. So what is done is the O'Sullivan hydrostatic maneuver. So fluid from a height at a great pressure is brought and a suction cup is placed over the inverted uterus, and that fluid gradually will help the uterus get everted. Okay, sometimes in an edematous long-standing inversion, the cervicovaginal ring is very thick, so you may have to cut that ring and then reposition. These are usually done under anesthesia. So what is done is that the inversion is attempted if it has happened in front of you. If you're able to revert it, well and good. If you can't, then all these are done under anesthesia in the operation theatre. If this also fails, a last approach is an abdominal approach where a laparotomy is done. You can see this fundal dimpling. Okay, it's gone in like this, and here you have the fallopian tubes like this. Is called a flower pot appearance. In the last attempt, laparotomy karke, you gradually with Alice forceps take out this inversion from the top. Okay, this is called the abdominal approach. Very important topic is amniotic fluid embolism. This is very important because of its sudden nature. It can happen to anybody, any low risk patient. It can happen during labor, and it's a very sudden event. It has a very high mortality, and it takes everybody by surprise. So what is happening here? The intravascular compartment is entered by amniotic fluid and its contents, and that causes embolism and triggers DIC. So what happens? The patient has collapse, usually following delivery. Immediately after delivery, the patient collapses, followed by bleeding because of DIC. Okay, and this is very typical of AFE. So it's not bleeding followed by collapse. Bleeding followed by collapse is usually PPH. Collapse followed by bleeding is usually amniotic fluid embolism. This is the criteria which Williams gives to define amniotic fluid embolism: sudden onset of cardiopulmonary arrest or both hypotension and respiratory compromise. Second is DIC following the initial event. Third is onset or during labor, and many times this can happen also. You do an ARM, this happens, or you have started oxytocin and then suddenly the patient collapses, or within 30 minutes of delivery. And very importantly, there is no fever, because if fever is there, then the cause could be sepsis. So sepsis is ruled out. It happens during labor or very soon after delivery. DIC following initial symptoms. And what are the initial symptoms? There is cardiorespiratory collapse. Next topic, and so what do you do? Treatment is supportive. You shift the patient to the ICU, quickly deliver her if she hasn't delivered, shift her to the ICU, and supportive management is done. So now we continue with injuries to birth canal, and what you need to remember from this chapter is this table. Okay, so we have 4 degrees of injury. The first degree is when only the skin or only the mucosa is involved. This is a first degree tear. Second degree tear is like an episiotomy, which involves the skin, the mucosa, and the muscle. Okay, so skin plus mucosa plus muscle is a second degree tear, and episiotomy is a typical example of a second degree tear. Third degree tear is now when the injury has happened and it has gone till the anal sphincter. Now, this is further classified as 3A, 3B, and 3C. 3A is when less than 50% of the external anal sphincter is torn. 3B is when more than 50% of the external anal sphincter is torn. And 3C is when also the internal anal sphincter is also torn. So, 3A is less than 50% of the external sphincter. 3B is more than 50% of the external sphincter. And 3C is the internal anal sphincter also is now involved. And the fourth degree tear is the one which nobody wants to see, is to encounter, is when the anal sphincter and the mucosa is also involved. In the anal mucosa, please add here, the mucosa is involved, then it becomes a fourth degree tear. Okay, so this is classification of birth injuries. Now coming to obstetric instruments. Here we're going to cover the episiotomy scissors, forceps, vacuum, and a little bit about the instruments used in a cesarean section. Starting with this is an episiotomy scissors. We all know what this is. Okay, now what are the possible questions that can come here? Remember, we no longer do routine use of episiotomy. Episiotomy has to be restrictively used. Okay, and that means using it only when required, especially when anticipating difficult deliveries, like in the aftercoming head of breech, or if you're using a forceps or a vacuum, or if you're anticipating a face to pubis delivery, or if there is shoulder dystocia, you need room to do the maneuvers, or if you have a primi gravida and they usually have a rigid perineum. Again, not all primies. If the perineum you feel is rigid, then you can give an episiotomy. Now, what are the layers cut in an episiotomy? You have from inside out, you have the mucosa, you have the muscle, and the skin. And it's sutured in the same way. Mucosa, then muscle, the skin, using absorbable sutures, so the patient doesn't have to come back for a suture removal. They usually use a rapidly absorbable suture to suture an episiotomy. Also remember that and very importantly, the types of episiotomy. So this is the introitus. Okay, this is the anus. The episiotomy we can give is either a mediolateral episiotomy or a median episiotomy. Remember, a mediolateral episiotomy has many disadvantages. Okay, there is poor healing, there is more pain because it's asymmetrical, right? There is more incidence of dyspareunia, there's a higher incidence of dehiscence of wound, but we prefer to give it still because there is no damage if it extends. If it extends, there is no major structure here. But in a median episiotomy, what's going to happen? The biggest disadvantage is it can cause a third or fourth degree perineal tear if it extends. Okay, this is the major disadvantage. Although it has better healing, less dehiscence, less pain, still if it goes straight in the anal mucosa, it's going to end up with a tear. Now coming to forceps. Forceps, there are different types of forceps. There are traction forceps, rotational and special forceps. But the one which you use most commonly, is in fact the short forceps where the handle is short. Okay, and this is called a Wrigley's or an outlet forceps. This is the one you need to remember. Okay, and this is a type of outlet forceps. Outlet forceps can be applied when the fetal head is on the perineum. That means without separating the labia, you can see the head there. That is the time when an outlet forceps is going to apply. And second most important point is that the rotation, internal rotation, should be complete or almost complete. It should be less than 45 degrees. That means almost complete before you think of applying an outlet forceps. You can't apply an outlet forceps if the rotation is still yet to happen, if internal rotation is still yet to happen. So that's what you should remember, the two most important points if you're applying a Wrigley's or an outlet forceps. Also remember this mnemonic, the forceps mnemonic, FORCEPS. These are the prerequisites before applying a forceps. The cervix has to be fully dilated. You can't apply it in a cervix which is less than 10 centimeters. Okay, it should be applied in occipito anterior or occipito posterior. That means the rotation should be almost complete. Even it could be occipito posterior, that is face to pubis delivery. Membranes have to be ruptured. They cannot be intact if you're applying a forceps. C is, of course, you've ruled out CPD and you've taken consent of the patient. E is the bladder has to be empty and preferably give an episiotomy. This will give you more space. Okay, P is confirm the position of the head. Okay, and the other P stands for the pediatrician should be in attendance because you can expect birth injuries or you can expect a asphyxiated baby. And last is the sagittal suture. That means rotation should be complete. That means the sagittal suture should be in the occipito anterior diameter, and this is for outlet forceps, as outlet forceps does not cause rotation. This does not apply to vacuum. All the other points apply to vacuum. Okay, but rotation need not be complete with vacuum. Vacuum has the function of auto rotation, which is not there with an outlet forceps. So remember this mnemonic. These are the prerequisites of applying a forceps: fully dilated cervix, occipito anterior or posterior, membranes have to be ruptured, consent has to be taken, CPD has to be ruled out, episiotomy or empty bladder, position of the head is to be confirmed, pediatrician should be there, and sagittal suture should be in the anterior posterior diameter if you are applying an outlet forceps. Okay. Now, what are the advantages of a forceps? Remember, these four conditions are conditions where a vacuum cannot be applied. In a face presentation, in a preterm baby, in a dead baby, and in an after coming head of breech. These are four conditions where vacuum you can't apply. So, forceps is the best for any of these conditions. Also remember, fetal trauma is less with forceps, but maternal trauma is more because it's touching the maternal tissue. It is on the face. It can cause bruising on the face, but less. Vacuum delivery, remember, has more fetal trauma because it's completely on the baby's head, whereas forceps has more maternal trauma. Okay, and forceps is preferred if you don't want the patient to bear down. For example, so with forceps, you don't need additional bearing down effort of the mother. You just pull, baby comes out. Vacuum, you need the mother to bear down also. So if you're using a forceps in a condition, if you're using an instrument in a situation where the mother can't bear down or you don't want her to bear down, it is better to use a forceps. It requires less of maternal effort. Okay, what are the disadvantages? It requires more skill, more maternal trauma, and an outlet forceps cannot rotate. So if the rotation is incomplete, prefer a vacuum. This is how a vacuum looks like. It has a suction apparatus, okay, and it has the vacuum cup. The vacuum is applied on this point, the flexion point, which is a point which lies 3 centimeters anterior to the posterior fontanelle. Right, the center of the cup is a point which is 3 centimeters anterior to the posterior fontanelle. When you apply the cup here and you pull, you are going to cause flexion. If you apply the cup here and you pull, you are going to cause extension. Hence, this is not applied here. It is applied as back to the head as possible. What are the advantages of a vacuum? Advantage of vacuum, it has less maternal trauma, less skill is required. Auto rotation can be done. Okay, but the disadvantages are that in preterm, in IUD, in breech for the aftercoming head, and in face presentation, you can't apply it here, right? Other disadvantages, it causes more of fetal trauma. Okay, so these are the disadvantages and advantages of a forceps and a vacuum. Cesarean section, it's a huge vast topic. What you should know are the different types of cesarean section based on the incision that you're giving. The most common is a lower segment incision, which is a transverse incision, looks like this. Okay, how do we know where the lower segment is? Because the bladder has been reflected off. Okay, and this instrument you see here, this is the Doyne's retractor. This is keeping the bladder away from our field of surgery. So give the incision here. It's also called a Kerr's incision. This is a classical cesarean section or an upper segment cesarean section. Where do we give a classical cesarean section? If there's placenta accrete syndromes, if there is a carcinoma cervix, if there is a large fibroid in the lower segment, if there are dense adhesions in the lower uterine segment. These are situations, and in a perimortem cesarean section, many times we resort to doing a classical cesarean section. Vertical, so in the vertical, you can also give a vertical incision in the lower segment, very rarely done. Sometimes you give a lower segment and then you have to extend it because the baby is not getting delivered. It's a difficult delivery. So either extend it in a J-shaped fashion or extend it in an inverted T fashion. Okay, now whenever the upper segment has been entered, here, whenever the upper segment has been entered, this becomes a contraindication for a vaginal delivery the next time. The next time the patient has to have a repeat cesarean section. Only with the lower segment cesarean section can you offer a trial of labor in the next pregnancy. Okay. Now, a question that has come in the past is instruments used in a cesarean section. We use a knife and blade. We use an Alice forceps, artery forceps, a tissue cutting, medicine bomb scissors, a Doyne's retractor, very important, a green Armitage forceps, very important. This has an end which looks like this. It has a triangular end which is non-traumatic, atraumatic. Then, of course, needle holder and forceps for suturing are required. But remember, these two instruments have been asked separately also. Doyne's retractor, which looks like this. Okay, this is the Doyne's retractor and the green Armitage forceps. Another question which has come 3 times now in the last 4-5 years is this. What is this picture showing? This is showing the supine hypotension syndrome, which happens in term pregnancies. What happens when the woman lies down straight? The gravid uterus pushes against or compresses the inferior vena cava. Okay, and this is going to lead to hypotension and syncopal attacks in the woman. Now, if the same woman is undergoing a cesarean section, she's lying flat on the bed, she goes into hypotension because of supine hypotension syndrome, and then spinal anesthesia is given that further worsens the hypotension. So, she can go into acute hypotension if she undergoes cesarean section in this position. That's why whenever we do a cesarean section, the patient is tilted, please correct this, towards the left side. Okay, by putting a wedge underneath her right hip. Okay, so a right hip, we put a wedge, and this shifts the patient towards the left side. So a left tilt. Okay, even otherwise also we are advise the patient to sleep in the left lateral position because that improves circulation, reduces pressure over the inferior vena cava. So left tilt is given by putting a wedge under the right hip. Okay, so this is another very commonly asked question, supine hypotension syndrome, because of compression of which vessel? Compression of the inferior vena cava. And the last topic in obstetrics rapid revision is intrapartum fetal monitoring. What is intrapartum fetal monitoring? It is when, how do we know how the fetus is or what's the fetal well-being when the patient is in labor? We can know this by auscultating with our stethoscope, by doing, very importantly, and what is commonly asked is a cardiotocograph. You can also, although not done in our country, but fetal scalp blood can be sent for pH, for lactate. Fetal ECG can be done, fetal pulse oximetry can be done. So these are the different methods that can be used for intrapartum fetal monitoring. Now, this is how the CTG looks like. And CTG can be external, as you can see here, or it could be internal. Again, this is not commonly done. External monitoring, you can see you have a probe on the fundus. This is a toco probe which is going to measure the uterine contractions. And you have the fetal heart rate probe or the cardio probe which is going to check the fetal heart rate. And then you get a tracing like this. So here is the toco monitoring the fetal intrauterine pressure. And this is the cardio monitoring the fetal heart rate. Okay, and we see several things in this. The first thing we see is the baseline fetal heart rate. The normal baseline fetal heart rate is between 110 to 160 beats per minute. If it's tachycardia, it's more than 160. If it's bradycardia, it's more than 110. Tachycardia can be seen in cases of fetal distress. It can be seen in cases of maternal fever or maternal sepsis. It can also be seen when there is a fetal arrhythmia. Okay. Bradycardia again is a sign of acute fetal distress. It is also seen rarely in patients with fetal, if the baby has a fetal heart block or a fetal arrhythmia. Or if the maternal pulse is less, the maternal pulse slows down, then again you can have bradycardia. So this is the baseline fetal heart rate. Ideally, it should be between 110 to 160 beats per minute. The second thing we see is the beat to beat variability. What does this mean? Look at this graph. Can you see that it's a continuous wavy line? It's not a line which is like this, right? It has to be a continuous wavy line. Every second, the fetal heart rate is going to change, and this variability should be between 5 to 25 beats per minute. It should not be static. It should be a continuous zigzag line. This tells us that the baby is doing fine. If the variability is reduced, it can be seen either if the baby is sleeping in a sleep cycle. So it should not last more than 20 to 40 minutes. It can also be seen when there is fetal distress. Okay, so it is not a good sign to see absent or reduced variability. The next thing, and the thing we see more commonly in an NST. What is an NST? NST is the same thing as a CTG, but it is an antepartum test of fetal well-being. That means the toco part is not there because the patient is not in labor. We're seeing only the fetal heart rate part. So this is an NST, a non-stress test. And in an NST, accelerations are very important. In a CTG, they're not important. If they're there, we're very happy because that shows the baby is fine. If they're absent, we're not bothered. But in an NST, you have to see acceleration. So in NST, what happens is, what is an acceleration? It is increase of the fetal heart rate above 15, an increase above the baseline by 15 beats per minute or more, lasting for at least 15 seconds. Okay, and this acceleration, remember, is an important feature of NST. With fetal movement, what should happen? The fetal heart rate should go up. So when the baby moves, acceleration should be seen. that is a sign of a reactive non-stress test. Okay, but intrapartum, in during labor, accelerations are not very important. As I said, if they're there, we're happy. If they're not there, it does not mean anything. Okay. Next is decelerations, and this is the most important component which we assess and see in a CTG. Now, deceleration is the opposite of acceleration. A drop in the fetal heart rate lasting for 15 seconds or more is a deceleration. So, look at this graph carefully here. Can you see this is a deceleration? And look at the contraction. See the deceleration, look at the contraction. See the deceleration, look at the contraction. So, what are you noticing here? Every time the deceleration is happening, it is symmetrical to the contraction. When the contraction peaks, the bottommost part, the trough or the nadir of the deceleration is matching with the peak of the contraction. So this is a symmetrical deceleration, and this is called an early deceleration. That means they are symmetrically shaped. Okay, and early deceleration are a sign of head compression. So they're not worrisome. They are seen when the head is descending down, which is a normal part of labor. And if they are seen especially in the later part of labor, in the second stage or late first stage, they are considered completely normal because they are happening because the head is getting compressed. Why is the head getting compressed? Because it's coming down. The second type of deceleration is this one. One thing you can see in the CTG, there is no beat to beat variability. So it's already a bad CTG. But look further, can you see the deceleration is happening, the nadir, the trough is happening after the peak of the contraction has passed off. So you have decelerations like this, and this is the relationship with the contraction. This is called a late deceleration, and these are very bad decelerations to see. They are a sign of fetal hypoxia or uteroplacental insufficiency. The baby is not getting enough blood is what this deceleration is telling us. So you're late, you've missed the bus. That's what this deceleration means. It is an indication for immediate termination of or delivery of the baby by the quickest way possible. This is variable. Variable means there is no relationship. So you have decelerations happening and you have contractions happening. There is no fixed relationship between the deceleration and the uterine contraction. And these are typically seen when the cord is getting compressed. And when does the cord get compressed? When there is very less amniotic fluid. So in oligohydramnios, the cord gets compressed between different fetal parts and the fetus and the uterus, and hence there is no relationship between the contractions and the decelerations. Okay, so it's seen in oligohydramnios. And what is this? It's the last type of deceleration. This is a prolonged deceleration. Prolonged deceleration is when the deceleration is lasting more than 2 minutes. Okay, you can see it's lasting all this while and less than 10 minutes. This is seen typically in acute hypoxia, like there is cord prolapse, like there is intrapartum abruption. You will see this acute asphyxiated baby, and this is how it will present as a prolonged deceleration. Okay, and the last abnormal pattern, this is not a deceleration, but this is a sinusoidal wave pattern. This is typically seen in when there is fetal